Hello, everyone. My name is Walt Schoenborn, Director of Digital Media here at AuntMinnie.com. And I'd like to welcome you all to today's presentation entitled, The AI Tools Every Radiology Department Needs, How One Simple Software Upgrade Can Improve Image Quality, Workflow, and Patient Care. Today's presentation is brought to you by Subtle Medical. We have three presenters today. I'd like to start with Dr. Amish Doshi. Dr. Amish Doshi is an Associate Professor of Radiology and Neurosurgery in the Division of Neuroradiology at Mount Sinai in New York City. He serves as Vice Chairman of Ambulatory Services and Radiology, Chief of the Division of Neuroradiology, and Associate Director of the Radiology Residency Program. He has served on several national committees and currently serves as the Chair on the Corporate Partners Committee of the American Society of Neuroradiology and President of the New York Röntgen Society. Our second presenter today is Dr. Adoya Kurosura Solano. Adoya Kurosura Solano is an Assistant Professor of Radiology in the Musculoskeletal Radiology section at Icahn School of Medicine at Mount Sinai, ISMMS. Dr. Kurosura Solano obtained her MD from the University of Barcelona, Spain. In 2011, she completed her radiology residency at Hospital de la Santa Creu at St. Paul in Barcelona, Spain. She subsequently completed a fellowship in neuroradiology, a fellowship in oncology imaging, and a fellowship in musculoskeletal radiology at ISMMS, where she joined as faculty upon completion of her training. Our third and final presenter today is Dr. Timothy Dyer. Dr. Timothy Dyer is the Chief Medical Information Officer and Head of Musculoskeletal Interventional Services at East River Medical Imaging and Assistant Clinical Professor of Radiology at New York Hospital and Cornell Medicine. He completed fellowships in interventional radiology at St. Luke's Roosevelt Medical Center and in musculoskeletal radiology at the Hospital for Special Surgery. He was a radiology resident in the Mount Sinai Medical Center, where he was chief resident in his final year. All three of our presenters today have written and co-authored numerous peer-reviewed articles in several professional journals, as well as several book chapters. Enjoy today's presentation. The first question I want to bring up to you, it's going to expand from there, but I want to give everyone a chance to speak on it. What goals were your institution, trying to achieve using AI?
Yeah, I guess I can start with that. Thanks, Walt, for having us. And it's nice to be, part of this webinar. I think from, artificial intelligence obviously is a big topic in radiology, specifically. And the way I look at it, and I think our institution looks at it is there, clinical sides of radiology and operational sides of radiology, and artificial intelligence tools that can help in both aspects. And I think they're kind of two different, missions when we're looking at, AI tools. And in the clinical realm, I think it's how do we improve, our ability to diagnose, and how do you improve, patient safety. So ultimately, to prevent misdiagnoses, and kind of the second part of it is to improve efficiency, and triage, so, can you get to certain cases earlier in a list of many different cases? Maybe you're reading 50 cases. How do you triage a case that, is an acute case that comes through, and the AI technology can help with that as well. From the operational standpoint, it's, how do you maybe improve patient throughput, improve utilization of your machines by improving efficiency within the different modalities, such as MR, CT, ultrasound, but also patient safety as well. How do you improve diagnosis? So kind of combine both in that sense from an operational standpoint.
I'll just echo those thoughts. And I think the one additional issue that we've been facing, especially in private practice, Amish can speak to this about the more tertiary care hospital-based practices, but the one issue that we've definitely been facing over the past year through this period of the Great Resignation is losing technicians. Yeah. So one of the reasons that we've really looked into operational AI solutions within, especially the last 6 months, is to try and take some of the burden off of our technicians. So my thinking with implementing things like Subtle is if I can take a 20-minute or a 30-minute exam and knock off 5 or 10 minutes while still providing the radiologist with an equivalent study, I've now given those techs another 5 or 10 minutes of their time back that can be used to transitioning to the next patient, that can be used for things that they need to do outside of the scanning. And that's frankly a really, really important aspect of the AI implementation in our practice.
Yeah, one of the things that I've heard the most about, especially obviously in the last couple of years, is burnout and efficiency. And having something like Subtle that you can implement, obviously, as speaking more to where you were going on, was being able to lighten the workload, i.e. burnout, which I keep hearing over and over again, and obviously being efficient while doing that. I'm going to go on to something else that I had written down that I wanted to make sure that we kind of covered in this regard. And I guess the easiest way to pose it to you, how do you evaluate new vendors and new technology with everything that's out there, especially nowadays?
Yeah, I mean, I can jump into that. So I do, I kind of the physician who's overseeing IT at our practice. So I'm fairly involved in at least the very high level decisions about these things. And I will say we've gone through and looked at multiple AI systems and frankly, many IT solutions for other problems. And I think when I come back to this question, the overarching important aspect to me in terms of at least getting my foot in the door with these solutions is to have something that's fairly simple and easy to set up. The more complicated it is for my IT department to get into it, for me, it's a non-starter. And that's, of course, in addition to all of the important things that you need to look at, right? You need to make sure that someone is appropriately handling your patient's information, that there's no type of HIPAA violations. Yeah. But assuming that all reputable businesses are dealing with those things, the thing that I appreciate is having a clear process for getting things set up and not bogging down my IT team with setting up a lot of servers, making connections. The easier you can make it on us, the easier time I have of getting into these solutions.
Yeah, I'll definitely echo that, and just add that I think like at AI, there's kind of these two different models. There are groups of AI companies that are very hyper focused on one specific area, and then there's other AI companies that kind of offer a broad range of solutions. And the hospital setting, at least in kind of the hospital academic setting, generally we're encouraged to find one solution that takes care of everything. And it's not always the case, of course. And, so really the goal is to find an AI solution that addresses many, many things. And most of the things that would help with, some of the things we talked about, whether it's efficiency or patient safety or triaging, but also, maybe filling the gaps in with some of the other AI solutions for vendors that are tried and true. And that work well in different environments. And I think some of the AI companies that were early, kind of early to market, found their place in these various institutions for very specific needs. And now people are looking for bigger solutions and things like AI orchestrators that, you have something that many different AI companies can actually feed through. And these academic institutions or these hospitals or practices can get AI companies, individual AI companies coming through this type of orchestrator. So that's kind of where it's moving in. And I think that's kind of how we're looking at it. But just as an evaluation standpoint, I'll echo what Tim said. It's really what's easy, what kind of, can come in, be implemented easy, work well. The more complex it is, there's too many hurdles to jump over to really implement it well, and it really leaves a lot of room for errors, and that's where adoption actually starts to decrease with these types of solutions.
Yeah, I just say from my perspective, I'm fairly nimble, right? We have a practice that's less than 20 physicians. We've got 5-6 offices, so it's fairly easy for me to get things approved, get new hardware going, get servers stood up. but still, if you can come in with a process that doesn't require me to jump through all those hoops, it's a lot easier to implement. And I'm sure in the hospital, Amish can probably tell you, it's to have something that doesn't have to go through multiple layers of approval, that doesn't require new servers to be put in, is often a much easier solution.
Yeah, and to that end, well, first of all, I want to just make sure, Dr. Solano, can you hear us now?
Yes, I can hear you. Sorry.
Excellent. Great news. So, Connie, coming back to the second point, and we missed you for a little bit, but I would love your input on this. We're talking about evaluating new vendors and new technology, and where do you go in terms of making those decisions? Couple things for everyone that's here, that's participating. We have a poll that's launched. I strongly ask you to participate in that poll. We already have a ton of people that have already put in some data. So I want to thank you, first of all, for going ahead and putting in that information. So as we're talking about evaluating new vendors and new technology, it's interesting. Dr. Dyer brought up something where he's nimble, and everything that I've heard about is, it's almost 80 to 85% of the discovery and exploration of the process or what you're putting in, and then 15% is the final integration or implementation of that. And I always find that pretty fascinating, even on a smaller, nimble staff of 20 some odd people that are on your practice, to people, the larger hospitals and larger organizations that have hundreds. It seems to be that almost at 80 to 85% of discovery and trying to figure out and getting everybody's input. All the cooks in the kitchen want to have a say in it, and then the 15% are finally getting it done. So we talked about a couple of things, FDA approval, things like that. I want to bring up some examples of where this goes underneath this, and then maybe get your talking points by it. So we're talking about importance of clinically validated, importance of operational benefits, seamless IT implementation, what we just discussed, easy to integrate into existing practice without major workflow changes, without disruption. The companies are building end-to-end solutions, innovative pipelines. So you want to be able to see that there's going to be a progress as to what you're putting in, and any time that you might see something on a process improvement with your staff or integrating the software, they're going to be able to, that you see that there's going to be an end to that. And then finally, company values missions are aligned with ours. Increase access to higher quality medical imaging for all. So basically saying that, we know what it is that your company stands for. This is what we want to be doing, and having that be a part of your actual decision-making process of what AI you integrate. Sound pretty accurate?
Yeah,
I mean, there's that.
Go ahead.
Go ahead, Amish.
No, I was going to say. I mean, I agree. Those are the the basic points that that kind of fall into the mission of this of this kind of look at AI and how we integrate into radiology. So and I think different practices have different weights on what you mentioned as we were talking about. And I think that's an important consideration, and it really is relevant to how these AI solutions kind of migrate into practice at these different sites.
Yeah, I totally agree. And I'm sorry, Dr. Dyer, you were going to add to that.
No, I was going to make a couple points. I think first you mentioned a little bit about implementation, and one of the things that I was thinking about with implementation that I find helpful in terms of being able to try these things out is to avoid upfront hardware or software costs. I find that it's a lot easier to try things out if you don't have those. So for instance, we have Air Recon DL on a couple of our machines, which for those who don't know, that's GE's AI processing. But that requires hardware implementation, it requires software implementation to get that up and running, as compared to something where I can just hook up to a server with no upfront cost. It's a lot more difficult. So I think that helps in terms of deciding when you're going to evaluate these things. If you can just make a remote connection to these services, I think that's a lot of help.
Completely agree. So without any further ado, I did want to get into the next portion of this, and it's a follow-up. And the question I kind of put through this and knowing where this conversation is going to go, we're talking about, do you see AI tools like Subtle MR that are designed for accelerated scanning, operational efficiency as lower risk compared to diagnostic apps that triage cases or detect lesions?
Yeah, you know, the other point I was going to add to earlier is, Amish may remember that Amish and I were residents together, and we kind of passed through the first iteration of not AI, but computer-based diagnosis. And I think the biggest frustration with computer-based diagnosis is having it call too many things. So too many false positives. False negatives are obviously a concern as well. But my point about that is, if you're going to dip your foot in the AI world, getting into operational thing, I think is a easier first step. There's less concern, a little less concern about how it operates. You can tolerate, I think, a little bit more variability in AI processing of the image than you're going to tolerate, or you'll find your radiologists are going to tolerate a bunch of misdiagnoses.
I couldn't agree more with Tim. You know, I think that's for a real life application. We have both. You know, at Mount Sinai, we have AI solutions for the clinical triaging standpoint, and AI solutions for, you know, as subtle for you know, kind of what I call operational efficiency, right? You know, universally, our operational efficiency is accepted across the board. You know, it's from when we actually implement versus you know, we have implementation of the clinical solution, but not all of our radiologists use that on a regular basis. And I think, you know, there's a threshold for adoption that is constantly iterating, and they have to improve. But the challenge with that AI is that, you know, there are going to be people, there are early adopters, and there are people that are going to linger behind and not use the technology for whatever reason. And I think so, to kind of answer your question, yes, there is a difference in that. And I think it's much easier to kind of stomach the operational side of it than necessarily the diagnostic side, in my opinion.
Yeah, Dr.
Zoya, are you back in? Can we hear you?
Yeah. Can you hear me?
Yeah,
we can.
Yep.
Perfect. Thank you. Thank you for having me here, and apologize for all the technical issues I've had so far. But yeah, I just wanted to add to that. No, like, I think AI is a tool that are here to stay, that it's going to take a while until we all welcome it and will feel comfortable with it. I think it comes all to trust. We have to trust the tools. We have to validate them. We have to see how are the new images and get used to that. And Subtle, I think that it's an excellent tool that once it's deployed here, there is nothing additional for the technologies of the radiologists to do. So in fact, I think that once it is implemented, the radiologists, unless you tell them, they don't even notice. And we will show some cases that will prove that how comparable the image is. So it's just a matter of, you know, who wants to be in the first wave of this AI technology. And yeah, I'm very excited about this. It's exciting times in radiology, and I look forward to all the future developments that are coming.
Well, I agree. And when I was looking at that question, I started thinking about the operational IT aspect, and I started thinking about the radiologist aspect, and I wasn't sure how you guys were going to respond. And it's interesting, you brought up all the different perspectives on that in terms of integrating something like this. So Dr. Solano, you were able to sit out for a portion of this, so now I'm really going to bring you on the hot seat.
Okay.
So I do believe that you might have some slides that you want to share with us. And before you did that, I did want to set something up. You know, for you particularly, from being on the clinical side, I wanted to ask you, how did you evaluate Subtle? And based on that, you know, explain a little bit on, you know, the pilot, the imaging, everything that you did in terms of evaluating Subtle, and where you came to your decision on that.
Sure. Would you like me to start sharing the screens while I talk about that? Or?
I would love that.
Okay, perfect.
And if you don't mind, when you hit share screen, just to make sure there's two buttons at the bottom, just make sure that those are both toggled on. And We're good to go. We see the screen perfectly.
I'm using my iPhone actually for hearing because my microphone wasn't working on the computer. So hopefully you can hear me well. And then I'm using the computer to share my slides. Yeah. Okay. And you see when yeah, okay, perfect. So yeah, I just want to talk a little bit how was my experience, how I encountered my first interaction to Subtle and how we implemented this in our institution here at Mount Sinai and how we validate this new AI tool. So first, we sat with with the Subtle team and with the technologies, and we worked together in deploying the tool and making sure that we adjust the parameters in order to get the best image quality in our opinion, and decrease the time as much as we can without affecting what it was important to us, like the signal ratio and the sharpness of the image. So for that, we kind of had some volunteers patients or volunteers co-workers, and we set up all our parameters, and then we wanted to validate in the actual clinical setting in our institution in the outpatient setting. So I just want to share with you some slides of how we developed this small research project that we did here in our institution, and how what image features we assess and what were our results. So as I said, we wanted to compare the standard of care for the MSK, the knee MRI, with the accelerated sequences using the subtle enhanced MRI. We designed a project where we were gonna include 50 consecutive patients who underwent all in our 1.5 Tesla CT. As we have previously discussed, Subtle can be implemented to any vendor and any kind of field, but this is where we had deployed the software, so that's why our 50 patients were acquired here. We had to follow our standard of care first. So first the patient was scanned using our standard of care knee MRI protocol, and then the patient followed the subtle enhanced MRI. Our protocol for the knee MRI includes 5 sequences, which are axial PD flat SAT, sagittal T2 flat SAT, coronal T2 flat SAT, and coronal PD images. We also do routinely a sagittal PD images, but since it's already acquired and makes equal to 1, it didn't really take advantage of the decrease in the time. So this is just a very busy table where I just wanted to show you how we match the parameters as much as we could with our standard of care and subtle enhanced images. You can see how the parameters are almost comparable to all the in all the sequences, with like the decrease in the next. And I just want to emphasize how much time difference there was once we apply Subtle. As you know, Subtle acquires the images like in a fast image, and then there is like a post-processing improve imaging by denoising and improving overall the image quality. So what we did when we acquired with Subtle, we were able to decrease the time of overall the scan of more than 50%. We can see how when we add both all the sequences together, the conventional exam took about 30 minutes and 27 seconds. And with the subtle enhanced MRI, it decreased to 6 minutes and 45 seconds. So overall, we had like more than 50% of time saving with more than 6 minutes. So what we did once we have all the cohorts of these images, we asked 2 board-certified musculoskeletal radiologists to assess all the images, and we use a 3-point Likert scale. We analyze the images for image quality, for artifact, and for diagnostic performance. When we look at the image quality, we ask them to pay attention to some pre-chosen anatomical structure, like the cartilage, the patellofemoral ligament, bone marrow, menisci, and cruciate ligaments. We also ask them to look at the internal derangement, the most common pathology, and grade them to 1 to 3, depending if they thought there was not diagnostic, equivocal, or diagnostic. So our results were comparable in almost all the structures, anatomical structures that we assessed. There was, in all of them actually, no significant difference between the conventional, the standard of care protocol, and the subtle MRI protocol. The only one that we found some difference was in the axial PD fat sat. When we assessed for artifact, we encountered a slight worse performance, and I think this could be explained because there was a little bit of bias in the way we designed the exam for clinical reasons, right? Because our standard of care was always performed first, and then this was followed by the subtle images, and from the subtle images, the axial PD fat sat image was always the last one. So we have to put this into consideration, that this may have been due to patient having been there longer and having, as a result, a little bit of more motion artifact. But overall, the rest of the structures and not only in anatomical overall image quality, but also in terms of artifact and diagnostic, both sequences were comparable. So I'd like to show you some nice images that we have from our core that we recruit for this validation study. Here we have sagittal T2 fat sat images of a patient, 23-year-old female that came for knee pain. I want to show you here on the image that I'm showing on my left. This is the standard of care MRI sagittal T2 fat sat, which took around 4 minutes to obtain. You can see here the posterior cruciate ligament, anterior cruciate ligament pointed with the arrows. And on the right side of this image, we can see the same patient with sagittal T2 fat sat acquired with the subtle enhancement MRI. You can see here on the time that the conventional protocol takes about 4 minutes, and the subtle it decreases to 2 minutes and 7 seconds. So you can see the images are very, very comparable in terms of sharpness and signal noise ratio. Another patient here, a 50-year-old male with right knee pain, that you can see the anterior ligament is completely torn, appears very heterogeneous and irregular, and the same patient with subtle enhanced technique, you can see again the same findings, and I think we will all agree that the image quality is very comparable, that there was no issue doing diagnostic here, and there was not added artifact. This was overall a 1.54 time saving, so 52.7% decrease in time. Another example here of a 43-year-old female, you can see on the coronal T2 fat sat images. Again, we can see very sharp the images of the menisci. The bone marrow appears very comparable. We can see the medial collateral ligaments, the iliotibial band, and with 1.33 times saving. Here on the conventional, it took 3 minutes, 27 seconds, and the subtle enhanced MRI, we were able to acquire this comparable image quality imaging with only 1 minute, 54 seconds. Another example showing some pathology of coronal T2 fat sat. We can see a patient here with a radial tear close to the posterior root attachment, a lot of marrow edema and soft tissue edema. Here again with the standard of care MRI, which took 3 minutes, 27 seconds. And here on the right, the subtle enhanced MRI, showing again the same findings with the same sharpness and signal noise ratio. And we can all agree that the images are very comparable. It was hard, our readers were blinded from the sequences. They really couldn't tell which one was which. And the same patient here in a more frontal anterior view, you can see a subchondral fracture with reactive marrow edema. Again, with our standard of care and subtle enhanced MRI. And to finalize, we have an example of coronal PD. And this is a normal 16-year-old female that came for pain. And you can see again on the coronal PD how sharp the images are in the comparable subtle enhanced MRI. In this case, the time was 1 minute, the time saving was 1 minute and 9 seconds, which corresponds to 53.7 seconds. So as a conclusion, we could say that subtle enhanced MRI sequence were providing more than 50% scan time reduction with comparable subjective image quality, artifacts, and diagnostic performance as our standard of care.
Dr. Solano, that was fantastic. And I'm just going to go ahead and tee up some questions because I was privy to some of the information that I knew you were going to be sharing. And I think that you covered it all, but there's one point that I do want to bring up. So increased revenue. I think that we're going to be, you could make a easy argument based on the data that you just gave, that no matter how you look at it from a process and from a throughput standpoint with patients, that it's going to lead to an increased revenue for your operation.
Yeah, I think like you have to put into consideration how much time you're saving and how many scans you can add to that. There's one time that you are not saving, right? Like it's like how much time it takes to position the patient in the table and all these things that you add. But of course, you are saving significant time in the acquisition of the scanner. And we have also to think about another point that is very important here, which is patient comfort, right? Comfort. Especially in the musculoskeletal setting, which we have a lot of patients who are very uncomfortable with because we have pain. If we can bring them in and out of the scanner faster, it will overall increase their experience. And also we have to think about the fact that we are decreasing the waiting time for the patient to get the actual image, which is another problem that we encounter frequently in the outpatient and inpatient setting.
That was exactly leading up to what I was saying. And when you talk about revenue and you talk about increased operational efficiency, being able to throughput patients per day, so that just kind of ties into one another. The one question I wanted to ask you about was rescanning. How has Subtle helped you in that regard, reduced rescanning? Because that's a huge part of your throughput, efficiency, etc. So I was wondering if you could speak on that a little bit.
Yeah, this is not something that I have personally assessed. It will be a good study to see if we are decreasing the amount of rescanning, as you said, but I can anticipate that the number one cause why we rescan a patient is because there is too much artifact for us to confidently read the scanner and assess the anatomic structures. So if we are reducing the amount of time that the patient is indeed inside of the MRI, as results have been shown, like the artifact reduces, right? Like you have less motion artifact, and as a result, less rescanning. So this is something that affect with.
Right, and when you do need to rescan, to rescan a reduced time sequence is obviously going to be less painful than having to repeat a 5-minute. Repeating a 2-minute or 3-minute as opposed to repeating a 5-minute has a whole lot less penalty on your throughput.
Right. So even in the worst case scenario of rescanning, at least your time lapse there is going to be severely, impacted and decreased. Dr. Doci, I didn't know if there was anything you wanted to.
No, I mean, just as far as revenue, this is actually a very important consideration, right? I mean, that's one of the things, like, you throughput. And, I look at it right now, one of the issues that we're having, and I think it's a common problem, is, MR utilization. I mean, we have backlogs of patients trying to get scanned. So how do you increase the number of slots that you have in a day? And so Subtle is a great tool to use for this, and we've used it actually in real life to do this. And the way we've done it is that we've looked at where Subtle can be very useful in getting us some efficiency in the scans and reduction in time. And Dr. Solano actually pointed out transition time. I mean, transition time is I look at transition time as a it's a variable. Some people are faster in transition time, some people aren't. It's a very difficult thing to control. What we can control is scan time. If we can actually legitimately improve scan time, we can improve at least that factor that goes into a total time the exam would take. And that's what we used, at Sinai. And what we were able to do is many practices like ours, would have a model where scheduling would be done in 30-minute time slots. Some exams would be 60 minutes and some exams would be 30 minutes. So, I always look at it as an average day. If you ran a scanner for 10 hours straight, the max number of scans you could do is, 20 scans. With Subtle, you could actually create a different model. If you can actually get to some scans to 20 minutes and 40 minutes, so you might actually have a 20, 40, 60 model is kind of what I refer to. And then theoretically, you could do 3 scans max an hour. You're probably never going to get to that point, but you go from 20 to 30 theoretically. And so there's your kind of opportunity to do some more. And even if you did 2 or 3 scans more per day, so not 10, but 2 to 3, that's legitimate revenue that that you can produce. And that's where you can go back to, whether it's your practice or your hospital administration, and actually have a business plan to show them that that there's substantial revenue that can be generated from use of Settle.
And the more use that your techs get used to using the platform, to making it easier, even with the amount of rescans that you're looking at, when you're talking about exponentially, it's always going to lead up to a better revenue model for you in that regard. And I want to come back to that in just a second. There was something that I wanted to touch on because we're very unique with Dr. Dyer, coming from more of a privatized sector with what he's working with, and with you on the more clinical and hospital side of things that you're working with. I know that you also have some slides that you wanted to share with us, and I wanted to kind of tee that up at this point, if that's all right.
Sure.
And we're going to talk about a little bit more on clinical validation and review case examples of subtle enhanced images from your side, from the before and the afters, and being able to take a look from how you see it from your side of things. And then we're going to come back to Dr. Dyer in just a moment.
Yeah, sure. I just have a couple of slides. I'll go through them, relatively quickly. I think the big thing is, how do you kind of, begin the evaluation process and implementation of something like Settle? And you're obviously comparing it to your conventional, sequences or your conventional techniques. So, you're really, the goal is to, change the parameters, maintain quality, but improve scan time. And generally, Dr. Solano went through this, but, one way to do this is, obviously don't want to interrupt your daily workflow. So if you're doing this in real life, you might take one scan, evaluate it on 10 to 15 patients. If you're happy with that, transition one sequence and transition that particular sequence, and then go on to the next sequence. And you can do that, throughout the number of sequences to just see what you want to adopt and what you don't want to adopt. And generally what we did was we would review that with our neuroradiologist or our radiologist. And once we had a consensus, we optimized it. If there was an issue, we would actually optimize it with the Settle team. We'd go ahead and implement that. And this is just an example. You have a sagittal flare on the left, and that's a routine that's a little over 4 minutes, or 4.5 minutes actually. And then we had the initial Settle processing done, and we just felt there was a little bit too much noise. We went back to the team, presented the case. They were actually able to modify the processing to get the image on the right, which we were happy with. Here's just an example that they can actually provide some increased resolution, even if you've optimized your number of averages. So you're kind of speed, or you use some other techniques to speed up the exam. And this is actually decreasing the matrix size in the phase encoding direction, and you can see that there's some time savings here. Really maintains good image quality. Here's a denoising technique, and here's where they actually reduce. We reduced the necks from 2 to 1, and you can see a pretty substantial time savings here. And if I look at this, our image quality is, I think quite good, and very easily adopted by our radiologists. We also looked at this too. I'll go through this very briefly. We looked at conventional versus Settle and lumbar MR. Just looking at osseous and extraosseous structures, and just kind of decided looked at it qualitatively to see what was usable and unusable. And we really saw no difference in quality or legibility between our conventional sagittal T1, T2, and STIR sequences when compared to Settle. Here's spine survey. This was a great implementation. We really saved a significant amount of time. So you can see this was just by reducing the number of averages. And I think we can agree. Certainly, I think that there's a good. We maintain image quality in this case quite well, in fact. And this was almost a 9.5 minute time saving. So this has been completely converted at our institution to Settle imaging because of the substantial time savings. Walt, you're muted, I think.
Thank you so much, Dr. Doshi. I really appreciate that. Thank you. And it was great seeing insights from your side of it. At this point, I'm going to do a little bit of pivot towards Dr. Dyer, and I just wanted to talk to you based on coming from a more private, more of a smaller sector in terms of a tighter team for your practice. One of the things I want to talk to you about was, we just talked about, clinical validation. I wanted to talk to you more about results and ROI, if I could. And I really wanted to talk to you about the people within your practice, image quality, working with subtle. How has that been?
In terms of the radiologist dealing with the imaging you're asking about?
Yeah.
Yeah, I mean, I think, look, there's not magic to this. You're not going to always get something for nothing. There's always going to be some people who are going to say this looks maybe a little worse than that. But I think the important thing to always keep in mind is the balance of a couple things, right? Time for the patient, ease for the patient, time saved for the technologist, increased revenue by fitting in more studies, while the entire time making sure that the study that you're getting is diagnostic. So, you in any radiology practice, and I'm sure Amish and Adoya can speak to this, you've got a lot of different personalities with different ideas about things. So I want to be honest and transparent about the way these things are used, right? You're always going to have minor complaints. But I think in general, it's well received, right? So I think at the end of the day, if you look at it from the radiologist perspective, by and large, they're going to be happy with their ability to read the studies, as happy as they were previous to implementing something like Subtle. You're going to have technologists who are happier because they're saving some time. You're going to have administrators who are happier because they're potentially fitting in a couple extra studies into the same period of time. So I think, to be realistic, you need to understand that some people are going to always have different opinions, and regardless of how good something is, there's always going to be that one radiologist who's going to say, I don't like this. But I think in general, it's a win-win-win for really all of the different facets of the radiology system: technologists, administrators, radiologists, and patients.
I was going to say from the patient perspective as well. I believe from what I've heard from all four of you is that, or from all three of you, is that it's been well received from both on the radiologist and from the patient perspective. Yeah,
I'll tell you just anecdotally. I remember a while ago, Amish and I met with one of his lead techs, and I remember the tech. Of course, as radiologists, we're behind closed doors. Oftentimes, we don't see the patients. And I remember Amish's lead tech was commenting that when they implemented Subtle, the patients were really just shocked, right? They said, are you sure you guys got everything that you needed? I mean, this took 50% of the time that it took last time I was here. So I got the feeling from Sinai's lead tech that the patients really love the decreased time of the studies.
Yeah, I think, just a comment, that is, been, certainly we've seen that quite a bit on the scanners that we use Subtle for. And, the throughput, just getting through the patients through the scanner much quicker. Almost, similar to kind of a CT exam. CTs, take, we all know as radiologists, take very little time. You're kind of mimicking that, and people are shocked by that, especially people like, Tim was saying, people who have had previous studies, they have something to compare it to. And it's pretty significant change. So I think that's been a really positive benefit of the use.
Yeah, I like to add one thing to that too, about
Please.
The patient support and all that. I also want to add that this can be applied also to the pediatric population, which is an important part also in musculoskeletal radiologist section. So I think that decreasing acquisition time, it is especially important in the pediatric patients, and this is been proved also that you can apply it to that population. So that's my 5 cents there.
No, I think that's a fantastic insight. I think that we need to be looking at from, as Dr. Zier said, and as you said as well, you look at it from all facets, and there's a lot of stakeholders involved in all aspects of implementing anything new like this, and that the results are going to be positive at the end. It's just getting there, and from patient perspective, IT perspective, radiologist perspective. With that being said, we are up against it, and I'm going to get to the Q&A. Please, I encourage everyone, if you haven't participated in the poll already, please do so. Any further questions we're going to get to in the Q&A. We are up against it. Any questions that we do not get to today, I will make sure that they get to Dr. Dyer, Dr. Doshi, Dr. Solano, and the rest of the Subtle team. After this, feel free to email us at webinars@AuntMinnie.com. This will be available on demand, and everybody who's registered and attended will be getting a link to that, to letting them know how they can access it on demand. Last question for all of you. What do you think it's going to take for AI to be embraced and adopted at scale? Tips for others who are looking to adopt.
Yeah, if we're talking about, just kind of the individual AI solutions, I think it really depends on what those solutions are actually delivering. So for example, Subtle, and I could talk about that because we are using it, and this is exactly what we're doing, is scaling it. It's starting with one scanner and really seeing what the ROI is there, and amongst all the things we talked about, I think it's kind of what the practice is interested in doing, whether it's patient comfort, throughput, whether it's, revenue increase, or as what Tim said, tech satisfaction, improving, kind of how the tech's workday is, first adopting that, figuring out how that technology works, and then, scaling it to a broader group of, especially if you have a larger fleet of scanners. And I know that doesn't answer, that's just a part of the question, but that's kind of how we're using Subtle and how we've, kind of been moving towards scaling it across the system.
It's an extremely wide question, and that's why I left it for last. So I just wanted to.
Well, in terms of practical aspects of scaling too, right? I mean, that's where something like the Subtle model, where you're using an external server, is a lot easier to take to scale much more quickly. In comparison to something, I'll go back to the Air Recon DL, which requires hardware upgrades, software upgrades, right? It's very easy for me to quickly implement Subtle onto a large number of scanners in my practice. It's just changing a few parameters on the scanner and sending where those things get sent to for analysis.
Dr. Solano, I didn't know if you wanted to add anything onto there. I know it's a very heavy lift, cumbersome question regarding, what do you think it's going to take for AI to be embraced and adopted at scale? Tips for others who are looking to adopt, just from your perspective, just a couple of insights.
I agree with everything they said. I just wanted to add also that it's important to convince your radiologists and technologists that this is indeed an AI tool that is going to be very useful, that is not going to interrupt to the workflow, right? Like radiologists and technologists are very busy every day, and they don't want an additional tool that adds, more interactions, or that it's going to slow them down. So I think it is important, the trust that I spoke at the beginning, that they are comfortable with this tool, and that's how we can deploy this to all the scanners and to all the staff in.
Okay, guys. Well, unfortunately, we're up against it, so I'm going to do the lightning round of Q&A from the people that were generous enough to ask some questions that are here in attendance. I'm going to go ahead and start with the first one. What is the appetite for cloud-based products given data security interests?
Yeah, so Tim can probably answer this from his perspective. I'll just tell you, like, from our experience, we started with Subtle with on-prem solution, so on-premises servers, and we are moving towards a cloud-based. It was a long road. It is a long road. Currently we're in it to really get that cloud-based up and running. I've talked to others, who cloud-based solutions are just not an option for their institutions. Particularly overseas, some of the places overseas, and then the solutions are on-prem, and Subtle offers both solutions, which is great. So kind of depending on your work environment, your workflow, your workload, number of scanners that you use, you can do an on-prem solution. So the cloud-based doesn't necessarily need to exist in that model.
Yeah, I always had mixed feelings about both. I think both have positives and negatives. On premises, obviously, you have a little bit more control over where your data is. Issues with any breaches are a little bit more controllable by you. Of course, that means, though, that I need to allocate IT resources to dealing with that stuff, whether that's spinning up a server, maintaining the server. Cloud-based solutions, you've got someone who's taking care of those things that's not on the IT staff, so that makes it a little bit easier for me from a staffing perspective. I think I'm less concerned about going with a cloud solution once I've dealt with the company for a while and have confidence that they're adequately maintaining the patient information in the cloud. So I think there's positives and negatives to both. Rapidity of getting a system up sometimes is better for on-prem, sometimes is better for cloud. So I think you evaluate each of those things individually based on a number of different variables.
Yeah, and to just because I can speak to the answer on this, we had a couple of questions that came in. Do subtle PET and subtle MR software tools have the option to deploy both on cloud and on premises? The answer is yes. So I wanted to let people know that. There was another question, are both products FDA cleared and CE marked and available now? The answer to that is also yes. So I wanted to address that as well. There was an important question that came up. In your experience, how do you convince hospital administrators to implement AI in radiology practice?
I think, one of the challenges with AI is, again, it goes back to what we talked about, clinical versus kind of operational. I look at clinical as kind of a cost center, versus the operational as a revenue source. And that's where the challenge becomes. Now, I think on the clinical side, there's a lot of value in AI, particularly in ensuring that certain findings aren't missed. There's no misdiagnoses. So liability issues that occur, with reads, right? So something to kind of double check you, especially if you have something that's pretty robust. And I think that's kind of been the method of us approaching hospital administration for the clinical solutions. Also, just workflow efficiency. For example, in stroke workflow, we have an AI solution in stroke work for large vessel occlusion. They have an app actually that helps for communication. You can actually easily communicate with the stroke team and the neurovascular team very easily. And what that allows is patient throughput, with strokes much faster. They've actually shown this. And that's a really good data point to show the hospital that we can actually capture these patients quickly and move them through the system quickly, and there's no delays. And then I mentioned before on the operational side, I think that's a much easier kind of ask for the hospital administration if you can actually show them that there's quicker turnaround for patients and there's a potential source of revenue.
Dr. Dyer, Dr. Solano, anything to add on to that, or?
I mean, for me, it's a little bit less of an issue. I mean, I've just got to get a couple radiologists together in a room and convince them. So a lot less. I will just point out that the different models are probably easier or more difficult when you're dealing with a model where you have a large upfront cost, as opposed to something that has no upfront cost but a subscription or a per click fee. I think the latter is a lot easier to implement and use to prove the benefits, either operationally or clinically.
And we just brought you back. Thank you, Dr. Dyer. So I want to go back to something Dr. Doshi said. We are going to extend a little bit past the hour. I appreciate everybody who's here. We still have a lot of people that are here and interested and engaged with a lot of questions. So I want to appreciate Dr. Doshi, Dr. Solano, and Dr. Dyer, your time. We'll try not to get too far over, but I want to make sure that any questions we don't answer, I'm going to make sure that all the doctors on here get this, as well as the cell team. Quick question, and then I'm going to pose one last question, if that's all right. Dr. Doshi, before you talked about some AI companies that are specialized, and we're starting to see a lot more of those. I guess the question I have is, when you have a practice or when you have a clinical operation, Can single niche AI solutions survive on their own, or do they need to be compatible or live on a platform or suite of AI solutions? And I guess the last sentence to this, where is all of this going, might be a little, it might be difficult, and it might take us a little bit too much time, but I was curious about the niche and being able to integrate it to a platform of solutions.
Well, I wish I knew where it was all going. I have no idea where it's all going, but what I'll say is I kind of look at it in 3 different buckets. I look at it as the standalone solution. Something like, standalone solutions will survive if they have great value, right? In its own right, like something like Subtle, I can see that as a very unique company in that it has a standalone solution where you are actually generating revenue, right? You potentially can generate revenue amongst doing a lot of other things. So something like that can stand alone. There are other AI companies that, they have one thing that they're very good at, right? And it might not be like, let's say aneurysm detection. It's just not something that, we're going to necessarily pay for. And those are the things that I think are going to go through something like an AI orchestrator, or AI kind of marketplace, if you will, that, you contract with this marketplace, and that, these AI solutions come through, they're vetted, they're FDA cleared, and you can kind of select the ones that you're interested in. And then there's the OEM solutions like that GE, for example, or Siemens, or these larger companies come up with, and they can also generate orchestrators as well, but they might have their own solutions that when you purchase a new machine, they slap on, this to the package, just like, or you pay for an upgrade onto a machine, you have a solution that you can kind of add to it.
I think in the end, a lot of this is going to come down to ease of use, to be frank. I mean, you need something that if it's going to be used on the clinical side by the radiologist, is simple to get access to from PACS, whether it's a small, simple solution or a grand, big solution. If it's not easy to use, it's not going to be successful. Whereas if I think it is easy to access, you'll probably find it's continued to be used.
Quick last question. And it came up only because I found it's pretty interesting. And it came in and it said, in addition to increased revenue, increased patient comfort, and increased image quality, can you speak to green component and health equity advantages of Subtle? Less energy per patient, being able to extend scanner life, increasing image quality at community sites. Do you have any data points for these?
I saw that in the chat, or the question. I thought it's a really interesting question. I don't have any data points for that as of yet, but certainly energy usage, patient. I mean, we talked about patient comfort already, but kind of that green effect. I mean, everything is moving towards that. We're going to like zero helium and things like that. So this could potentially be in addition to that. I haven't thought about how to measure that, but that is an interesting
yeah,
point.
And I think just thinking about equity, right? You have the potential here through AI to get better quality images off of older hardware. So I think you're potentially bringing better imaging techniques to potentially areas where they weren't there before.
Yeah, well, I thought it was interesting. There's always the green aspect that I didn't really think about, and I think it might be one of those TBD things as you're utilizing Subtle within your practice and being able to see the results on that. But I want to thank you again. Apologies for going over time. We had a lot of people that were here. I want to apologize to any of the participants that had questions. I will make sure those questions are forwarded to the team. Just go ahead and I'm going to forward what we already have here. Any questions that come up, they're available to be sent to me at webinars@AuntMinnie.com. I will make sure to forward them to Dr. Doshi, Dr. Solano, and Dr. Dyer, as well as to the Subtle team. Doctors, thank you very much. I want to thank you guys for your time. Again, apologies for going over. I want to very much thank our sponsor, Subtle, that has brought us all this great insight and information. And most of all, I want to thank the participants that are here. Thank you from everyone from all over the globe. Very much appreciated. You'll be getting an email link giving you access to this on demand, where it will live in the webinar and video section on AuntMinnie.com for months to come. So we'll make sure that you guys have that information. We'll be sending you those links within the next couple of days. Dr. Doshi, Dr. Solano, Dr. Dyer, and Settle team, thank you guys so much for your time today.
Thank
Thanks,
you.
Paul.